Okay, so good morning, everyone. It's great to be here, and greetings from Helsinki, Finland. The more detailed title of my talk is as shown on this slide. Since this is a signal processing workshop, I should probably confess at the outset that this study involved remarkably little signal processing, unless, of course, you consider the human eye and human brain interpreting cardiotocographic fetal heart rate traces as a signal processing algorithm. Our article is currently undergoing a second revision round at a scientific journal, so we are keeping our fingers crossed for the good news in near future. Until then, however, let's treat this data as unpublished data. So, chorioamnionitis and fetal heart rate monitoring are both extensively studied, but surprisingly, they have largely been investigated as separated fields. We know a great deal about the biology of intrauterine inflammation, and we know a great deal about the fetal heart rate responses to hypoxia. However, we know remarkably little about the inflammation, how the inflammation modifies those physiological responses during labor, and that was the knowledge gap we wanted to address. Especially we asked whether clinical or histological chorioamnionitis alters fetal heart rate deceleration responses to intrapartum hypoxia, and whether such alterations are associated with fetal acidemia or neonatal HIE. Before I move to the study itself, let me briefly introduce the setting in which the work was conducted. The photo shows the Women's Hospital, my home institution, and the largest maternity hospital in the Helsinki University Hospital District. Approximately 9,200 babies are born in this building each year. Across the entire hospital district, there are around 18,000 deliveries annually, accounting for 1/3 of all the labors in Finland. This study was based on 317,000 deliveries in the Helsinki University Hospital District over a 20-year period. Among these, we identified approximately 3,500 newborns with umbilical artery acidemia, defined as pH below 7.1. This represents the largest cohort of acidemic newborns studied to date. We then classified the acidemic newborns into 4 groups according to the presence or absence of chorioamnionitis and neonatal HIE, enabling comparisons of fetal heart rate responses across the full spectrum of inflammation and neurological outcomes. So, few words about the terminology. Clinical chorioamnionitis was diagnosed according to the major international obstetric societies, and histological chorioamnionitis according to the Amsterdam consensus criteria following placental examination, as you can see here in the slide. To capture the fetal response to intrapartum hypoxia as comprehensively as possible, we analyzed 4 key physiological variables. We classified fetal heart rate responses using 3 complementary measures: the frequency of deep decelerations, the frequency of shallow decelerations, and the cumulative decelerations area, which reflects the overall burden of deceleration activity. Uterine activity was assessed separately by contraction frequency, allowing us to distinguish changes in fetal heart rate responses from differences in the hypoxic stimulus itself. This was our first key finding. Among acidemic fetuses, exposure to chorioamnionitis was associated with markedly increased risk of neonatal HIE. Importantly, chorioamnionitis was also associated with more severe form of HIE. Perhaps the most intriguing finding was that this excess risk occurred despite less severe acidemia. So chorio was associated with moderate but not severe umbilical artery acidemia, suggesting that inflammation may reduce the fetal brain's tolerance to hypoxic stress rather than simply increasing the severity of hypoxia. The key message is illustrated by the shift in these allocations. The yellow parts and the curve representing to the right, representing choreo-exposed HIE cases, is displaced to the right towards milder acidemia. The blue allocation representing HIE without chorioamnionitis lies further to the left, indicating more severe acidemia. Yet, despite the milder acidemia, the chorioamnionitis group experienced more frequent and more severe HIE. So, the most interesting fetal heart rates, I think, occurred during the last 3 hours before birth. Until then, deep decelerations increased similarly in all groups. Thereafter, fetuses without chorioamnionitis continued to show progressively more deep decelerations, whereas those exposed to chorioamnionitis showed the opposite pattern. Instead, shallow decelerations became increasingly common, indicating that inflammation was associated with a shift in pattern of fetal heart rate deceleration response rather than simply a reduction in decelerative activity. An obvious question is whether these differences simply reflect a stronger uterine activity or more intensive labor management. The answer seems to be no. Uterine contraction frequency increased in the same way in all study groups. Likewise, we found no differences in oxytocin augmentation, maximum oxytocin infusion rates, progression to the second stage of labor, or the duration of active pushing. Together, these findings suggest that the fetal heart rate responses observed in chorioamnionitis cannot be explained by differences in the hypoxic stimulus or obstetric management. We also compared the clinical and histological chorioamnionitis. Histological chorioamnionitis was associated with a 2.5-fold higher risk of the HIE than clinical chorio alone. Interestingly, however, the fetal heart rate pattern were remarkably similar. Deep decelerations area and uterine contractions did not differ between the two groups. The only significant difference was a higher frequency of shallow decelerations in cases with histological choreo. Finally, we examined the role of funicitis, a histological marker of the fetal inflammatory response. Importantly, funicitis remained independently associated with HIE after adjustment for acidemia severity. This suggests that fetal inflammation contributes to brain injury beyond the severity of acidemia alone. To illustrate the mentioned fetal heart rate responses, I'd like to show you an example CT tracing from our cohort. This is a nulliparous woman at 40 weeks of pregnancy who developed fever during labor. This tracings represent a continuous CTC recording from the same one fetus during labor. Initially, the upper tracing shows the expected physiological response to recurrent hypoxic stress with deep decelerations throughout the upper tracing and into the early part of the lower tracing. Then, as you can see, something changes. Instead of the expected deep decelerations, the tracing evolves into pattern dominated by low amplitude shallow decelerations. Importantly, the shift from deep to shallow decelerations occurred despite uterine contraction frequency continuing to increase rather than decrease. In other words, this suggests that the hypoxic challenge is not diminishing. Instead, fetal heart rate responses is changing. Despite only moderate umbilical artery acidemia, this fetus developed moderate HIE and placental histology confirmed chorioamnionitis. So, what can we conclude from these findings? Firstly, chorioamnionitis was associated with a higher incidence and greater severity of neonatal HIE, despite similar uterine activity. Secondly, among newborns who developed HIE, chorioamnionitis was associated with higher umbilical artery pH, indicating that the excess brain injury could not be explained by more severe acidemia. Thirdly, fetuses exposed to chorioamnionitis exhibited attenuated fetal heart rate responses to intrapartum hypoxia with fewer deep deceleration, reduced cumulative deceleration area, and shift towards shallow deceleration. Taken together, these findings support a dual model in which choreo may both attenuate fetal cardiovascular responses to hypoxic stress and reduce the tolerance of developing brain to hypoxic ischemic injury. If this concept is confirmed, inflammation may not only make fetal compromise more difficult to recognize during labor, but also increase the likelihood of brain injury at the lower hypoxic burden. The biological mechanism underlying the attenuation of fetal heart rate responses remain unknown. However, every important discovery, I think, begins with the hypothesis. And hypotheses can be tested. So future studies should investigate whether fetal inflammation, cytokine-mediated neuroinflammation, maternal or fetal hypothermia, and altered fetal cardiovascular adaptation together explain the reduced tolerance to intrapartum hypoxia. So, this is our exceptional chorioamnionitis research team. I'm incredibly fortunate to have worked with such talented colleagues. Some of them are familiar faces to many of you, others may be meeting you for the first time through this work. Before I finish, I would like to acknowledge someone who should have been here with us today. Professor Alistair Gunn was not only one of the world's leading scientists in fetal and neonatal neuroscience, but also an extraordinary mentor, collaborator, and friend. His insight, generosity, and unwavering commitment to improving the lives of newborns have shaped our field and influenced countless researchers and clinicians around the world. It was a privilege to work alongside him, and his wisdom will continue to guide us long after his passing. So, thank you all. We miss you. Thank you.
Thank you, Mikko. Very interesting and beautifully presented work. One question from the audience or comment? Yes, please.
Thank you for your really interesting talk. I wondered if the finding about deep decelerations compared to shallow decelerations was surprising to you. That there was more shallow but less deep decels associated with choreo, if I understand.
Yeah.
Was that surprising to you?
Well, it was because we also studied the umbilical cord abnormalities, so tangled cords and the knots and every other placental findings, and still there was no difference between these two groups. So I think that it is quite a surprising finding. Yeah.
Thank you for your really interesting presentation. So just kind of in the conversation of choreo, where we know clinical choreo and then histologic choreo can be different things.
Yeah.
And so taking that back to how do we then use this information in the clinical setting where we're not going to have the histologic specimens, obviously, because that's an afterwards thing. How do you see kind of looking at it through also a lens of clinical choreo potentially, and how that may affect how we can interpret that if we're clinically seeing signs where we're concerned versus sometimes we don't at all as a clinician?
I think that the maternal hyperthermia is the one thing. It's something that we have to still study, but when we excluded those histological choreo cases, still the clinical choreo was associated with an adjusted odds ratio of 1.4 to the HIE. So it seems that the clinical choreo is also very important finding.
I will take one more question.
Hi, thank you very much for this very interesting talk. Do you have the chance at looking not at decelerations, but on the baseline? So do you notice a rise in baseline? And if so, was there a cutoff where you can say we have a 15% rise in baseline, 20% rise in baseline, or an absolute number of rise in baseline that is associated with choreo?
No, actually the decelerations were the only the fetal heart rate change that we investigated in this study. But I think that if we have a look at the baseline rate also, we should have seen that the tachycardia is the main finding there. So.
Thank you once again, Mikko. And for you who think about further questions, save them for the last 10 minutes after our next speaker.